Can you see my screen?
Yeah.
All right. Thank you very much. I'm very honored to be here. I thank you, WSPOS, for remembering me. So I'm going to talk about the role of botulinum toxin in residual and consecutive strabismus. So whenever you face complex strabismus that you know ahead of the first surgery that this patient might need more than one intervention, or you have a large angle deviation in an amblyopic patient, or whenever you have paralytic strabismus that you have to wait for surgery, and patients with several previous procedures, one thing that you can think of is about botulinum toxin injection. So as David Granite said in a previous webinar, I think botulinum toxin for me is like a tool in my toolbox, just like several other techniques as a strabismus surgeon. Sorry. So what are the advantages of botulinum toxin? It is perma, so it produces no scarring. It takes a less anesthesia time, and in adults, you can inject in the office. And it is a less invasive procedure, so sometimes it's easier for the patients to accept that as a second procedure. And depending on your healthcare system, it can be lower cost both for the patient and for the healthcare system. So botulinum toxin, we do have to remember that it relieves contracture. That is something that is not achievable with surgery. And it acts on muscle fibers, but not on scar tissues. So we do have some limitations whenever we are talking about reoperations. So whenever we are doing for over or under corrections, we have to remember that works best for deviations up to 20 prism diopters, and it produces better results in medial rectus because of the characteristics of the singly innervated fibers. I have to raise a point for 6 nerve palsy. It was the first approval for botulinum toxin use back in the 80s, and is very useful both in acute and chronic palsies. So in this video, you can see how I inject botulinum toxin using Mendonça's forceps. And it's a very easy and nice way of injecting with the closing conjunctival approach. And you can use the same way in children and adults. So when to inject botulinum toxin? You can inject before the first surgery in those complex cases, like I mentioned. For example, for 6 nerve palsy, because it can help you to differentiate complete versus partial. You can gain time whenever you have to wait for surgery in acute cases. In 3rd nerve palsies to partial cases, and before you split the lateral rectus if you want to transpose to medial rectus to relieve the contracture in very chronic cases. And in thyroid eye disease to reduce the deviation to be operated on, especially in acute cases before you have the fibrotic tissue established. So here a case, to example, a 13-year-old girl with a large bilateral 6 nerve palsy and a large ET. She was injected in the office a couple weeks before the surgery whenever I transposed her both superior rectus and recessed her medial rectus. And she has a good result, even though it's still with a hypo that will be operated later. And intraoperatively, you can also inject botulinum toxin. For example, again, in the 6 nerve palsy, whenever you want to do full vertical transposition of superior and inferior rectus, or you want to augment your medial rectus awakening, in large angle exotropia and esotropia to augment your RNR or to augment your BMR. And Dr. Hunter has some very nice studies on that. And previously operated strabismus if you have a previously fully recessed muscle. So let's go for an example. This boy had a medial rectus recession followed by botulinum toxin injection intraoperatively to augment the weakening of the medial rectus and the superior rectus transposition to the lateral rectus with a very good result even after 2 years. Then he lost follow-up and came back to me 10 years after with a 40 ET. So I performed again injection in his medial rectus of botulinum toxin. I did a resection of his lateral rectus, and in the fellow eye, a medial rectus recession he's still with an early post-op with a good result. Another example of a lady with sensory XT with several previous surgeries and a status of a prephytesis bulbi, but with normal IOP and wanting new surgery. So she had an XT of 35 with a right hypertropia. And whenever I went for the surgery, the medial rectus was a little bit recessed. So I advanced and resected, and the lateral rectus was found fully recessed. So I performed botulinum toxin intraoperatively in her lateral rectus and inferior oblique anteriorization with a very good result. And we can do after surgery. Again, in the sixth nerve palsy, whenever you have a residual small angle after transposition surgery, and consecutive esotropia, which I think is one of the best indications for botulinum toxin in residual or consecutive deviations. So whenever you have an undesirable diplopia in adults or in children, when you have a medial to large angle that you know is not gonna exodrift, or in a persistent small angle that may produce amblyopia. And in residual esotropia, because it's less risky to develop consecutive exotropia, and it works both for infantile and acquired esotropia. And again, Dr. Hunter has a very nice paper on that. And in consecutive exotropia, it's less effective. Dr. Dirmit has already taught us what is the best approach, and I totally agree. And residual exotropia also has variable results. So let's go for an example of a residual esotropia for sixth nerve palsy. So this boy had botulinum toxin preoperatively. It was performed Mendonca's transposition, which is under review for publication, but this publication, he explained his technique for high myopes, and then for sixth nerve palsy, he will do the same. So split lateral rectus, embrace the superior rectus, and then also embrace the inferior rectus and attach again in the sclera. And this was the result, but with 10 ET and diplopia. And so it was decided to inject again in his medial rectus, and now after 6 months with a very good result. And consecutive esotropia, like I said, I think is one of the best indications. So this lady, she had a alternate exotropia, was performed on RNR. She turned into a ET of 15 with a lot of complaining. So I performed Botox injection in her medial rectus. She switched fixation, and she was still with AT of 12 after a couple months. So I decided to inject in her fellow eye in the medial rectus, and she has been ortho since then with a stable result. So when we think about botulinum toxin, whenever we have a sixth nerve palsy, either before, during, or after surgery, whenever you have a consecutive or residual strabismus, either during surgery in large angle deviations or in previously operated muscles, and after surgery in small angles, and remember that we have better results for esotropia. I would like to thank WSPOS, Dr. Aline Correa, Marcela Barrera, and my fellow Carolina Zuccoloto. I'm very honored to have had to meet Dr. Alan Scott and have a couple learnings from him, and Dr. Thomas Mendonça, which I already told him yesterday when I saw him that I think he's our Brazilian Alan Scott, and I'm very honored to have been his fellow. Thank you very much.